All right, let's jump right into this explainer and build some definitive, high-yield mastery of polyarteritis nodosa for your USMLE prep. Look, if you're studying for Step 1, 2CK, or 3, you already know vasculitis can be a massive headache. They all just kind of blur together, right? But today we're stripping away all that extra noise. We're going to focus purely on the absolute most testable, board-relevant facts for polyarteritis nodosa, or PAN. And we're going to use some killer mnemonics to lock it into your brain for good.
Okay, picture this. Here is your absolute best hook for test day. PAN is the systemic vasculitis that attacks medium-sized arteries literally everywhere in the body, but mysteriously it completely spares the lungs. This is a massive differentiator. Seriously, if a board question gives you a patient with weight loss, skin nodules, and neuropathy, but then points out their chest x-ray is totally clear, boom, PAN should immediately jump to the top of your differential.
So what's actually happening here? By definition, polyarteritis nodosa is a systemic necrotizing vasculitis characterized by fibrinoid necrosis, and those are absolute board buzzwords you need to know. It predominantly affects medium-sized muscular arteries. That means it doesn't mess with the veins, and it classically spares the tiny vessels like capillaries. This inflammation narrows the vessel lumen, which obviously causes ischemia, but it also weakens the vessel wall itself, and that's exactly what leads to those highly testable microaneurysms.
Moving on to diagnosis. To remember the clinical presentation, just remember to eat pancakes.
This multi-system disease packs perfectly into this one mnemonic. Let's break down the PAN part first. P is for postprandial abdominal pain. You see, the gut needs a lot more blood flow right after eating, but because those mesenteric arteries are narrowed by the vasculitis, the patient ends up getting intestinal ischemia, basically intestinal angina. Next, A is for angiography showing microaneurysms. Biopsying deep visceral arteries is super dangerous, so we rely on imaging to spot these classic beads-on-a-string microaneurysms, usually in the renal or mesenteric circulation. And N stands for neuropathy, specifically mononeuritis multiplex. This is an asymmetric polyneuropathy that hits named nerves. So think of a patient who suddenly develops a right foot drop, and then a few weeks later, a left wrist drop.
Now for the cakes. C is for cutaneous lesions. Think levato reticularis and those deep, painful subcutaneous ulcers. A is simply for arterial inflammation. Now pay attention to the K, because this is absolutely vital. Kidney involvement. PAN causes severe hypertension by revving up the renin-angiotensin system, but, and this is a huge board concept, there is no glomerulonephritis. You are not going to see red blood cell casts here. Finally, E and S stand for elevated ESR and using a skin biopsy to actually confirm the diagnosis.
Next up, disease severity, which brings us to the king.
Determining severity is crucial because it dictates our whole treatment plan. If your patient has any of these king features, they are instantly classified as having severe PAN. K is for kidney failure. We're not just talking mild hypertension anymore, we're talking full-on renal infarction and tanking kidney function. I is for intestinal ischemia, which can rapidly progress to bowel infarction and perforation. That's a surgical emergency. N is for neurologic stroke. It's rare for PAN to hit the central nervous system, but when it does, it is incredibly severe. And G is for grave cardiac involvement, like a myocardial infarction, which happens when those medium-sized coronary arteries get inflamed and blocked off. If the king is in the room, you have to treat aggressively.
Let's shift gears to viral links, specifically the classic hepatitis association.
You simply cannot talk about PAN without talking about hepatitis B and C. When you see a patient with this combo, I want this mantra repeating in your head: kill the virus, save the vessel.
Think about it. With idiopathic PAN, we usually want to suppress the immune system. But here, the immune system is actively reacting to a virus. If you just hammer them with immunosuppressants right out of the gate, that virus is going to run wild. So here's the actual protocol. For Hep B or C-associated PAN, if it's mild, your #1 priority is treating with antivirals first. Let the body clear the trigger. Now, if they have severe disease, say a really bad acute kidney injury, you can use short-term steroids and maybe some plasma exchange to quickly clear those circulating immune complexes. But that's strictly a bridge to save the organ until the antivirals kick in. You want to avoid long-term immunosuppression unless they just totally fail antiviral therapy.
All right, let's pivot back to treatment for the majority of cases, step by step.
For your idiopathic, non-viral PAN, the pharmacological game plan depends entirely on that severity classification we just talked about. If they don't have those king criteria, meaning it's non-severe PAN,
We treat them with oral prednisone plus a milder steroid-sparing agent like azathioprine or methotrexate. But if they do have severe PAN like an ischemic bowel or an impending stroke, we need to bring out the heavy hitters. We're talking pulse IV methylprednisolone paired with a really strong cytotoxic agent, cyclophosphamide.
To keep this straight on exam day, just get this rhythm in your head, pred to cyclo to AZA. Step 1 is pred. You always induce with steroids. Oral prednisone if it's mild, IV methylprednisolone if it's severe. Step 2 is cyclo. For severe cases, you add cyclophosphamide for about 3 to 6 months to aggressively shut down that inflammation. But you can't leave them on cyclophosphamide forever, right? The bladder and bone marrow toxicity is just too high. So, step 3 is AZA. Once you achieve remission, you transition them over to azathioprine or methotrexate for long-term maintenance, usually for about 18 months total. Pred, cyclo, AZA.
But hey, what if the disease just totally ignores your steroids and cyclophosphamide? For those rare, incredibly stubborn cases, we do have salvage therapies. Just remember MRTT, mycophenolate, rituximab, TNF inhibitors, and tocilizumab. Biologics like those TNF inhibitors and tocilizumab are actually showing some awesome success in retrospective studies for patients who fail the standard stuff. It's super high yield to know you've got these backup options in your pocket.
Let's talk prognosis. Just remember the letters O, H, G.
Look, untreated PAN is absolutely brutal. Without treatment, the 5-year survival is basically 13%. Yikes. But with the treatments we just went through, that number jumps all the way up to 80%. That said, mortality risk spikes if the patient has any of the OGI factors. O is for older age, specifically being over 65. H is for heart involvement. G is for GI involvement, like that mesenteric ischemia we talked about. And I is for insufficiency of the kidneys, which is strictly defined as a creatinine greater than 1.7. If a question asks you for the strongest predictors of mortality, look straight for the OGI.
Okay, rapid review time. Lightning round. Let's lock this all in right now. I'm going to read the question, and I want you to mentally shout the answer before I say it. Ready? Question 1. What vasculitis classically causes renal and mesenteric microaneurysms? That's PAN. Question 2. Which major organ system is classically spared by PAN? The lungs. Question 3. What's the induction drug of choice you add to steroids for severe PAN? Cyclophosphamide. And question 4. What is the classic viral infectious association you absolutely must test for? Hepatitis B and sometimes C.
Nailed it. Master those concepts, and you're going to crush any polyarteritis nodosa question the boards throw your way. But before we wrap up, let me leave you with one final thought to test your broader knowledge. We know PAN classically spares the lungs, but what small vessel vasculitis characteristically target the lungs and the kidneys together? Think about your ANCA vasculitis. Thanks so much for hanging out with me for this explainer. Make sure you follow @Step2Bites for more AI-powered, high-yield medical content that turns these complex USMLE topics into memorable visual stories. Keep studying hard, and I'll see you in the next explainer.